We call it controlled chaos because it is everything your body does not want to do, we are forcing your body to do. Your body wants to jump when it's being cut by a knife. It wants instinctively with spinal cord reflexes to grab whatever that threatening object is that is inflicting pain. It wants to stop breathing. It wants to breathe faster. We are fighting your body at every single level, pretty much.
I had surgery a couple of days ago, and I found the entire process fascinating. I find it amazing that we have access to anesthetics and nerve blockers, which effectively allow doctors to switch a person off before disassembly, reassembly, and then turning them back on safely at the end of the day. For me, the anesthesia didn't feel anything like sleep at all, but rather like I stopped existing. That's what this conversation's about. I speak with Anthony Kaveh, who's a Stanford and Harvard trained anesthesiologist. Anthony also runs a YouTube channel where he educates people about anesthetics and the therapeutic use of psychedelics. In this conversation, we discuss how anesthetics work, what they can teach us about intelligence, mental health, and perception, and also whether anesthetics cause brain damage. I'm Shane Farnsworth, slowly recovering, and this is the Escape Sapiens podcast, supported by the Andrea von Braun Foundation. If you enjoy these conversations, you can help support them by liking, subscribing, and sharing. And now, here's Anthony Kaveh explaining what happens to your brain on anesthetics. I hope you enjoy.
Escape Sapiens.
How has your work as an anesthesiologist impacted your perspective on consciousness, life, and death? Are we nothing but machines?
Very, very insightful question. And we are far more than the machines that we're familiar with today, far more variables, if you will, than any iPhone or computer that you've probably ever used. And the mysteries really come out when we begin to turn off some of the cogs and dim some of the light bulbs because of the incredible amount of inhibition that is there for us to do everyday activities, meaning that when we actually can turn off some of the daily humdrum of our routines, more interesting phenomena begin to arise.
Can you give some sort of an overview in broad strokes? What happens then to a person's brain as it begins switching off and you're pulling these levers and putting them under?
What a fascinating question, because the brain has so many parts to it. Maybe you've heard of the mammalian brain or the lizard brain or the primitive brain, and all parts of the brain, certainly they're not as discrete as we make them sound, but there are different levels of organization that are turned off almost in a stepwise fashion as you get deeper and deeper under anesthesia. And it's actually quite intuitive that the first parts to turn off are the parts that are evolutionarily, we believe, to be the most recent. So high-level thinking or complex thinking, language. And as we turn those off, what's next? We have our ability to move, eventually, if you go deep enough, our breathing is impaired. And if you go even deeper, because anesthesia fundamentally affects nerves and neurons, it will eventually senesce or turn off neurons in the rest of your body beyond your central nervous system. And the most dangerous one is going to be your heart, because your heart is many neurons connected together with muscle. And when you turn those off, the heart will eventually slow down, and eventually stop beating. But we don't let anesthesia get there. We want to find a happy balance between where you are not remembering, and fortunately, memory consolidation is pretty high on that list that I gave you. And then sometimes we need you to not move around for certain surgeries. So we're talking about turning off nerves at a pretty, if you will, superficial level. We don't want to go to the deep, deep levels, with the exception of some surgeries where we do need to actually turn off parts of the brain for reasons of energy and metabolism. If we are unable to deliver oxygen to parts of the brain that would otherwise be metabolically active and would die if they weren't actually turned off. So those are some very rare surgeries, but that's the vast minority.
Are we just lucky that things turn off in the order that they do? So for instance, I could imagine a situation where you put someone under and they immediately release their bowels or something like this, but that doesn't happen, right? So is it Is it that we've chosen anesthetics that are specifically directed at turning off the brain in a certain order, or a human special in their physiology, or what's happening there?
This is protective mechanisms across, I believe, all mammals and probably even other animals that I don't deal with, like reptiles, because we want to stay alive. So the parts of our brain that are critical to the heart beating and us breathing, which are really the two most important mechanisms to keep you alive, are the most resistant to the medications that will ordinarily turn off nerves. So there's a lot more complexity behind this, but this is not by accident that across all animals, it's hardest to turn off the most primitive parts of the brain, because the brain wants to keep those alive, and it is presumably, if you will, through natural selection, made those the most resistant to being turned off by the most classical inhibitory molecules, of which many exist in nature. Modern anesthetics are highly refined forms of some chemicals that naturally exist. Look no farther than the opioid epidemic that we have here in the United States. One of the very first medications to ever be synthesized and purified was morphine. And sure enough, morphine will turn off all sorts of cellular processes before it eventually reaches the nerves that will stop you from breathing and lead to what we call respiratory arrest. So I can't give the why answer, but it looks like naturally there is a strong impetus to preserve the primitive brain as much as possible. And that's the brainstem and the spinal cord.
So then what's happening at a circuitry level? You obviously have some way of monitoring and measuring what's happening in the brain as you send someone under. And so what are the signals that indicate to you that this person is unconscious, this person is under the effect of the drugs? What are you, is it, so let me throw out some things that could be. Are you looking for voltage, frequency changes, distribution of the signaling in the brain, decoherence? What is it that actually goes on, and what do you see in theater?
I was actually going to ask you what you thought, and you answered my question. Well, in reality, we don't use any of those. The vast majority of surgeries are performed using surrogates for consciousness, which are like, Mr. Smith, are you awake? Can you hear me? Are you in pain? Typically, we use what's called the eyelash reflex. I think there's probably a more formal name for it, but if you stroke someone's eyelashes and if they don't move, it means that and if they're not responding to your voice, it means that they are not remembering anything and are unconscious, at least to a depth that's appropriate for one to begin the anesthesia process. You can measure surface electrical activity in the form of EEG, and we do this for many surgeries. It's just not the majority, because there is cost of consumable equipments and durable equipment that realistically it just does not provide enough value for the average surgery for it to be employed on a wide scale. But like you said, there are certain frequency and voltage differences that will change. If you look at an awake person, you're going to see various frequencies be very active with high amplitude. And as you turn off the nerves literally by pushing the levers with anesthesia, you will see that you see that amplitude decreases and frequency typically decreases as well. There are exceptions depending on what frequency band you're looking at. And there are some cases when we actually want to turn off what we call an isoelectric line in the brain. Those are those rare cases that I mentioned where we want to really turn off cellular activity to preserve energy and the metabolic activities of cells when we're not providing blood flow to those cells. So otherwise they would die if the energy requirements are not being met. So it's one of the many manipulations that we do. Now, there are also some medications that actually will render you unconscious, but will have the reverse activity on the EEG, meaning that they'll give you higher amplitude, higher frequency, once again, based on the frequency band. So it's not uniform for all agents that render unconsciousness. But for the most part, you're seeing decreased activity and decreased consumption. The real exception is the medication ketamine and nitrous oxide. These two, nitrous oxide is also known as laughing gas. These actually excite the brain. And as you can imagine, there are some cases you would not want to use them, especially if you're trying to preserve your cellular energy stores. You don't want to give those medications, for example.
So you avoid those. But in that case, what's happening? You have some large signal that's overriding the underlying brain signals that would be connecting the different regions of the brain. What's happening there with ketamine?
Well, these are also dose-dependent responses, to be clear, because and this is actually a very fascinating area of study as we try to learn more about psychedelics and what we call the default mode network. At certain doses, you will simply have lack of coherence because nothing is speaking with, these are all anthropomorphic ways of describing a very complex structure, but communication between parts of the brain that are not immediately adjacent to each other will begin to fall off. We lose that, what you mentioned, coherence. If you look at the phase of signals in different parts of the brain, you'll see that they are no longer in sync with each other. But the bigger question is, at lower doses, when we're talking about especially low dose ketamine, for example, which has similar properties to some psychedelics, what are the parts of the brain that we're turning off that might not affect consciousness as much as it affects self-perception, self-representation, identity, etc.? And it's very interesting that for the last couple of decades, people have been learning about psychedelics, whereas for hundreds of years, we've known that certain medications can alter consciousness. And there is some overlap and some profound differences, not only in the dose, but the fundamental mechanisms of how they disentangle certain parts of the brain. The default mode network being one that is disabled with ketamine and psychedelics, but it's a little bit different for other medications like the Michael Jackson drug propofol does not disentangle those networks in the same way that ketamine does. I don't mean to use broad words, but I'm just saying that if you look at the surface EEG, you'll see that the networks that are being disrupted look different between different medications. And then in the case of certain plant substances like those that are fungally derived.
But so then in the surgery room itself, are you able to tell? So you said you don't use an EEG to measure during surgery. You use these other sort of proximate measures of consciousness instead. But
heart rate, blood pressure, respiratory rate are by and large, we're covering 3 or 4 standard deviations almost for what the average surgery is going through. The EEG is really just looking at the proprietary algorithms that some companies have developed to simplify the frequency and amplitude changes that I described to you, so that literally we can go based off of a number as a surrogate for consciousness and memory formation in surgeries where those surrogates are inappropriate or inadequate for ensuring adequate depth of anesthesia.
Can I ask then, because I had this image that you had these monitors and that you'd be able to tell even what sort of drug was being administered if you walked in the room. But by the sound of it, you use different measures. And so can I ask, how individualized is what you do? Do you bring them down and bring them deep and put them under, or do you sort of gently bring them to, right across the bound? What's the actual approach that you take? What's standard procedure?
Very good question. First off, there is no standard procedure because every individual is different, every surgery is different, and the means of accomplishing that surgery for that individual will therefore be highly different. In many cases, not all, but to your first point, there are certain signatures that you can roughly estimate based on the surface EEG. So what your assumption, the assumption you stated is not entirely inaccurate. It's just not one that's practically employed in the majority of surgeries across the world. With regards to the standard procedures, there are some standard. The World Health Organization, for example, does have a list of essential medications that you can do the majority of surgeries with by having this handful of 5 to 10 anesthesia-related medications. However, realistically, and this is where theory and reality simply just don't mix, we have things called drug shortages where the most common medications are sometimes not available. And in anesthesia, it has forced us to not only adapt, but also to recognize that you can do almost any type of anesthesia with any medication you have. The loss comes on how fine-tuned you can be. And this is something that when I was a resident, I remember someone said this. They were actually from Germany. They were an invited speaker, and they said, you can do anesthesia with any medication. You just have to know how to use that medication, because the majority, and I can't say any surgery, but the majority of surgeries you can, quote, get by in a safe manner. This is where anesthesia, being a 0 and 1 binary, has some benefits, because if you're in an austere environment where there isn't adequate medication, formularies, etc., you can get by 0 and 1. But there's a cost to this, and that cost often goes under-recognized. So I wish I could say what the standard procedure is. I'll say that propofol is one of the most commonly used medications for the induction of general anesthesia. That's the Michael Jackson medication. It's white because its stability is ensured with this lipid emulsion that's primarily from soybean oil. So that's why it looks white. It's not egg white or anything, but it stands out. It's the only white medication we have in the world like that, at least to my knowledge. And most general anesthetics are maintained after you fall asleep with the propofol, maintained with some form of anesthesia gas. These are fluorinated, halogenated agents. They end with the words ANE.
So that's the mask that goes over?
It's actually the breathing tube that delivers
Okay.
the gas, typically. In some cases, you can use a mask, but it's not feasible to hold a mask over somebody for hours and hours. So a breathing tube is used, especially if the patient is paralyzed and is unable to actually generate a breath because their muscles are paralyzed. We need to breathe for them, and that's why there's a ventilator. The ventilator delivers these gases. So those are the most common medications that we use, propofol and one of these halogenated agents that are vaporized and then inhaled, often with a ventilator pushing that mixture of oxygen and anesthesia gas into the patient's lungs.
So one of the things that I'd like to understand better is how benign the process is, right? Because my image as a patient, I go to the hospital, I get put under, I wake up, everything's fine. But how benign is it? Am I the same person when I wake up again? Are there cognitive impairments that can occur, particularly when you're under for a longer period of time? Are you able to sort of shed some light in that area?
What a good question, because certainly everyday activities can cause us to behave differently. Imagine the death of a loved one, a traumatic accident, et cetera, et cetera. Well, surgery is a trauma. How often is one literally cut open? We call surgery, we call the operating room. In the US, we call it the operating room. Elsewhere, I know they call it the OT or the operating theater. We call it controlled chaos because it is everything your body does not want to do, we are forcing your body to do. Your body wants to jump when it's being cut by a knife. It wants instinctively, with spinal cord reflexes, to grab whatever that threatening object is that is inflicting pain. It wants to stop breathing. It wants to breathe faster. We are fighting your body at every single level, pretty much. Your heart wants to slow down. We have to speed it up. We are literally pushing everything in the opposite direction. That can have a toll, but we have never measured, because once again, we view anesthesia in a very 0 and 1 way, which is appropriate when we're first learning what these medications are. And if we're dealing with life or death, it's a 0 or 1 phenomena. So it's not inappropriate to say the anesthesia was successful or not. But if we ask questions, we'll find very quickly that there are some cases where there are long-term changes. It's most visible in those with the lowest cognitive reserve. Cognitive reserve is, like it sounds, how much extra I guess, how many extra light bulbs do you have upstairs? When individuals have a stroke, for example, depending on the part of the brain where the stroke occurs, they might have cognitive deficits after. Well, there's certain variables that we know confer higher cognitive reserve on a population level. Higher level of educational attainment, for example, the absence of mental health disorders like depression, etc. And there's a long list. And interestingly, they are rather modifiable. Unlike your intelligence or IQ, which appears to be a little bit more ingrained, these are lifestyle modifiable factors, which is very good news, even though we don't talk about this with patients, unfortunately. Cognitive reserve, the less of it you have, like when you are elderly, because there is an age-related decline in cognitive function. In the vast majority of individuals, no matter how hard we try, there is some natural degradation. Those individuals were the first to be observed to have long-term cognitive impairment after surgery, upwards of 20 to 25%, depending on the individual and the type of surgery. So when grandma breaks their hip and has a hip replacement, there is a 1 in 4, 1 in 5 chance that they might not return back to being as bright or sharp or as independently living as they were prior to the surgery. But we don't know if it's because of the anesthesia, because like I said, there are so many other variables going on. Your body is undergoing this incredible trauma from the surgery, which releases so many inflammatory factors that we know affect the brain. You are being given anesthesia, so it could be from the anesthesia, or it maybe could be from the underlying pathology itself or the underlying disease. So for example, if you're coming in with cancer and you need to have the cancer removed, maybe it's the cancer that's contributing to the cognitive impairment that is simply catalyzed by the surgery process. And one of the most interesting levels of evidence we have that the anesthesia actually may not be the main contributor is that when we do surgeries without general anesthesia, meaning we numb the nerves with a spinal, like we put the needle in the back, and we provide anesthesia by simply numbing and giving you just a hair, just a hint of anesthesia so that you're not fully aware of the banging and the knocking and the drilling and all that, because that can be a little disconcerting. Those cases seem to have similar rates of cognitive impairment, meaning that the general anesthesia appears to be not a variable or a predictive variable at all. You can numb an arm and they still have the same risk, for example, even if you're not fully asleep. So we don't know why, but we know that cognitive reserve appears to correlate. And that's very good news for us because, once again, we can affect our cognitive reserve at any stage in life. But this is very preliminary, very preliminary about how much, because we don't have a good way of measuring cognitive reserve at all. So how do we predict? We know that if a patient wakes up delirious after surgery, meaning that for a prolonged period of time, their light bulbs are just haywired. Imagine like one of these horror movies where different lights are turning on at different times, kind of stochastically, and there's no pattern. It's just like nothing is coordinated. That happens in individuals that we believe are susceptible to cognitive decline, and they might spend more than just 1 or 2 minutes after waking up being disoriented. They might be disoriented for days at a time. And those are one of the predictors for them not being fully with it after they recover from that delirium as well.
And you say that's up to 25% for elderly people, beyond what, 60, 70?
Well, I don't recall the exact cutoff. I want to say it's in the order of 65. And there is variability, of course, because these studies, they try to look at one type of surgery. So for orthopedic surgeries, which in the elderly are going to involve broken hips most often, which can be very serious life or death situations. But these are still few and far in between. We've been studying this for maybe 5 years, simply because measuring that outcome requires a battery of neurocognitive tests, which is time-consuming and expensive. And let's face it, most people after having their hip replaced don't want to be taking an hour-long neurocognitive test. So I'm sure more data will come in because it is such an important area of study, but we just don't know. We can't predict very well who is going to be in that 1 in 4, 1 in 5. The other question, which is very important, is the other extreme of age, which is the developing brain in the infant or the child, because those consequences might be much more severe because they have a whole lifelong of potentially impaired cognition or lower IQ. Fortunately, the data there time and time again has shown that at least brief exposures to general anesthesia, even if they're repeated a couple of times, do not appear to impair IQ, at least not repeated across many studies. Some studies have shown concern, but by and large, the risk benefit of, pardon me, but letting a child die or have a physical impairment for the rest of their life seems to be much more than the risk of anesthesia hypothetically having an issue.
So how long then can you put a person under? Let's say, for example, I went in for a routine. Let's say, for example, I went in for some routine surgery, and heaven forbid, something goes wrong in the surgery and it becomes much more complicated and the surgeons need more time. How much time can you give them?
You can theoretically be asleep forever. Right? Until your muscles atrophy away, because we can feed you with feeding tubes, we have ways of delivering fluids and glucose and proteins and essential fatty acids, etc. We can keep the body artificially alive in a comatose state for years. The question that you're getting at is, what are the consequences to doing so? And providing more time under anesthesia and the order of hours is typically inconsequential, assuming that there is a sufficient reserve cognitively, cardiovascularly, with your kidneys, etc. So giving an extra hour or two typically is not an issue. The issue arises when a surgery has gone haywire. There has been tremendous blood loss. There has been damage to vital organs, or perhaps that the reserve was insufficient, for example, for your heart. And now your heart can no longer keep up with the demands of the surgery because your heart rate needs to increase commensurate to the stress level that your body is undertaking. And as your body stress increases, for example, with the invasiveness of the surgery, if the heart can't keep up and it has a heart attack, that will be a limiting factor in the scope of the time domain of surgery, more than how much general anesthesia can your brain handle.
Right. So one thing that I have sort of leading on from this is I've always wondered what the difference is between putting someone under for a coma and putting someone under for a surgery. When you're putting someone in for an extended period of time, so you're putting them into an induced coma. What's the difference there in terms of drugs?
I think a Greek philosopher, I don't know which one, but I think a long time ago, someone answered this. They said, the poison is in the dose. Mm-hmm. It's often very similar medications, but used at different doses, and recognizing that there are half-lives that are not linear for these medications. We call them context-sensitive half-lives, where the half-life is a function of the duration of exposure to that medication. So you can really keep someone in a sedated state for an extended period of time with relatively low doses because of the accumulation of the medication throughout the body in various tissues, even outside the brain.
So if I understand correctly, the difference between inducing a coma and having someone in surgery is just you have a low dose, constant propofol or something similar like this, but you have to continuously give them the drug. It's not that you put them into a coma and then later on you can take them out of it with nothing having to be done in between.
You are correct that it's by and large very similar medications, different doses. But the part about having something done in between, I didn't follow.
Okay, so here's what I don't understand. I only experience this through movies, right? You have some person who's been put under, they're in some induced coma, and they seem to just be lying there with some breathing apparatus, but otherwise there's nothing happening. There's no anesthesiologist running around making sure that they're fine. Whereas I imagine in the operating theater, you're there, you're monitoring, you're making sure everything's fine. Am I just misunderstanding what's going on here and how these two procedures, are they the same procedure, just at lower doses, or are they really inherently different objects?
No, you're
Is I
very
guess what I'm
correct.
trying to find out.
Yeah, they're very similar. The difference being that in the operating room or the operating theater, there are constant manipulations to the body through the surgery, and the body's trying to fight those. That requires careful management, whether it's titrating more medications, giving blood. There's so much variability in that surgery that it's simply not there when someone is sedated in, for example, an intensive care unit. And that's why you don't need the same level of monitoring. They are still monitored on a whole bunch of monitors, but you don't have an anesthesiologist one-on-one with them. You may have like a nurse that is following maybe two patients and just monitoring vitals from a different room. They don't need that TLC, as we say, that tender loving care of having to be hands-on with them minute by minute or second to second.
I see. And when it comes to cognitive reserve, can you tell when you're there in theater, can you tell, hey, this person is pretty cluey, this person's pretty smart, this person, are you able to get some understanding of what sort of a person they are?
What a fascinating question. I believe in some cases you can have some clues. The big caveat being that we're not judging anybody, we're not calling anyone dumb, we're not making fun of anyone. But in some cases, when the anesthesia dose is low enough, what we might call sedation. So let's say you're having surgery on your hand. You typically don't need to be under general anesthesia if it's a relatively minor surgery on a finger. We can numb that area up to avoid the exposure and the risk of having general anesthesia, a breathing tube, etc. In those cases, if one has an established relationship with the patient, it provides a fascinating opportunity to speak with the patient if the physician is so inclined. And when you speak with patients, there's two variables that I view as pretty independent. One is the anesthesia requirement. Some individuals need more anesthesia. Maybe there's some genetic reasons that we don't really know yet, though there is some interesting data behind red hair. We know that people that have chronic exposures to sedative-like substances, alcohol, marijuana, etc., need higher dose requirements. That's one issue. But the other issue is how with it is somebody when they're getting anesthesia. And if somebody has a high requirement, but is also coherent at those higher requirements, that is very interesting to me. It's suggestive. I don't have any way of proving this yet, but it is highly suggestive that they seem to have a high cognitive reserve, because as you're stepwise, like we said at the beginning, turning off light bulbs one by one, they're still able to have a conversation, sometimes an intellectual conversation. And one of the most dramatic experiences of this I had was a physician himself who, as he was under sedation, he was looking at his own vitals on the monitor, and he was asking me questions about his vitals. Why is my blood pressure doing this? Why is my heart rate doing that? Why is my oxygen saturation doing this? And he was at a dose that would probably put me out, might have put you out. I don't know how much alcohol you drink or something, but I'm a pretty straight arrow. I don't think it'd take very much to put me out. And so the difference between these two variables is that you can have a high anesthesia requirement and be disinhibited. That is not suggestive, to me at least, of cognitive reserve. But if somebody has a high requirement and is coherent with it, suggests to me that, this person's an outlier and they're really with it. So I'm assuming that if they had also, for example, had age-related decline in cognitive function, man, if today they're doing this well with anesthesia on board, I would imagine 10 years from now, without anesthesia on board, they would probably still be quite sharp or witty.
Could it also just be a sign of how physically robust the patient is as well?
Well, that's a very good point, because these are not siloed phenomena. We know that cardiovascular health, diabetes control, cerebrovascular disease all worsen cognitive reserve. So I can't say what that chicken and egg thing is here about the causation. I would assume that the more cardiovascular fit you are, you're going to have a higher cognitive reserve, and that might explain the observation.
One of the things I wonder about is, when people are under the influence of alcohol or drugs, this sort of thing, they lose their inhibitions, and you see people doing all sorts of wild things. I imagine, especially since you use fentanyl in the operating room as well, right? A lot of the drugs that are on the streets are also in the operating room, as far as I understand. And are you able to tell? So when I'm assuming that people lose their inhibitions, are you also able to tell anything about, is this person depressed? Are they lonely? What's going on in their life? Do they sort of babble about the things that are going on, or are they really out for the entire time? What can you learn about a patient? Yeah.
What a fascinating question about this book, if you will, that can open up under the right circumstances. So it depends on the surgery, first and foremost. If you're having an open heart surgery, you are going to be so deep, maybe you're going to cool your body down on top of that and make you hypothermic so that you can withstand, like we were saying earlier, lowering metabolic requirements of cells in your body. You're not going to be talking. We're not going to be seeing what's going on because you've just hit the body with a sledgehammer. There is no signal left. However, your question comes up for the surgeries where individuals might be under sedation, for example, which is still many surgeries, especially as we have more and more fascinating nerve block techniques that we use with an ultrasound to, for example, numb up certain nerves in your shoulders and your neck and your arms and your hips and your legs, where we can do relatively large surgeries without the necessity for the sledgehammer of general anesthesia, which will blunt those fine signals of interest that you mentioned. Now, if you have a I like to call it an elegant anesthetic, but a low dose, giving the patient the right amount, not erring on the side of extreme caution, which is the easy thing to do, because if someone is just sledgehammered out, you don't have to deal with them. And I don't mean this in a disrespectful way to any patients. I'm just saying the reality of medicine, which is unfortunate, is that it's just easier to have a patient who's not talking, who's not moving, who you don't have to deal with. Mm-hmm. I don't think that's respectful. I don't think that's an elegant practice of medicine. In some cases, it's necessary, absolutely. But in many cases, realistically, you could give less anesthesia. I like to think that maybe it confers less risk. Well, I don't like to think, and we know it does. It's in those cases, I would like to call it kind of on the threshold, where somebody is still with it enough to perhaps be able to speak. Perhaps you can actually judge how much anesthesia they need to speak or to be quiet, as opposed to the sledgehammer. Then you will see that disinhibition can reveal fascinating things physically and psychologically about a patient. The easy examples are when people open up about what is going on in their life. And I can't even tell you the number of fascinating conversations I've had with people thinking that I am their husband, trying to romantically make gestures on me, thinking the list, is very inappropriate and very, very long, partly because of the disinhibitions, but it also makes you wonder, why does this individual in this moment of such immense vulnerability, what is the rationale? I don't think we can just say it's random, it's stochastic, it's because they're under the influence of drugs. Nor do I think it's appropriate to say that they're crazy, which unfortunately, I will say you, behind closed doors, this is what is spoken. Mm-hmm. Because some individuals also have very high requirements out of proportion to their body weight, which is one of the normalizing factors we use for dose of medications and commensurate to the type of surgery. So, for example, if a patient needs a whopping dose just to have a little needle prick in their finger, I don't think it's appropriate to say, oh, they're just crazy, they're just high strung. I think there's something else going on, because we have a high volume of data showing just how much mental health affects pain perception, affects the pain threshold. We have so much information about how mental health, whether because the medication is used to treat the mental health condition or because the mental health condition in and of itself affects anesthesia requirements. This is in addition to the patient overtly telling you things, which does happen. But we know that the actual dosages, if you are on the threshold and not the sledgehammer, that says something about the patient that I don't think is random. And then you have the patients after surgery who develop complications. It's very easy to say that, oh, there's a 1 in 5 chance of having complication X. But that's not true That might be true on a population level, but for the individual, why is it that patients with anxiety have higher rates of particular complications? Why patients with depression might have other types of complications more frequent? Of course, they might be socioeconomic. They're not necessarily purely from the biochemistry that's being changed from depression. But there is a tremendous link there that if you want to deliver the right anesthetic and have the right surgical experience and practice good medicine, you need to acknowledge.
Wait a second. So if you have a patient who's on the operating table and they're freaked out, they're scared, they're not sure of their environment, they're worried about what's going to happen, that influences how much of a drug you need to give them?
That can influence the amount of drug. It can influence how effective the drug might be. And it can influence how they're going to wake up after anesthesia. It can influence how their surgery recovery is going to be.
Is that just adrenaline? What's going on there?
Well, we don't know the answer. It's likely because adrenaline is one of the commonly released chemicals in these states. Maybe it's from cortisol. Maybe it's from dopamine imbalance. Maybe it's from serotonin imbalance. I mean, the list of chemicals is very long. We don't know. And these all work in synergistic ways that I can't pretend, nor can anyone pretend to really know. But the effects are not overblown. They're not so much that we cannot address them with anesthesia and have a successful 0 or 1 outcome. I'm not saying anesthesia is ineffective. You give enough, you will make anything happen. But what I am saying is that if we want to observe what's happening without a sledgehammer, there are individual differences that correlate very closely with that anxiety state that you just mentioned. One study from France actually showed that if you're doing a nerve block on a patient who is anxious, it appears that the effectiveness of blocking those sodium channels in those nerves that you're injecting lidocaine next to appears to be less effective than the individual that is not as anxious. Now, this is just one study of many. And of course, there's going to be conflicting studies for outcomes that are as subjective as pain. But I can think of numerous chemical and non-chemical reasons for that. And at the end of the day, it influences whether that surgery is going to be ultimately successful or not. Another example is the amount of anesthesia, that propofol that I mentioned, that white medication, the amount that you need to give. Some studies have shown that you need to actually give more to patients that are anxious for them to actually fall asleep because they are so wired up that the effect is there and reflected in how much nerve suppression medication you have to give. It's not 50%, 100% more, but it's some significant double-digit percentage more, at least in some studies. So my point here is, imagine if you are this anxious before surgery, well, how are you living the rest of your life? And we call it episodic anxiety. If you have anxiety before surgery, a lot of people have anxiety. That's hopefully a one and done phenomena. But if that's your steady state level of existence, that raises serious concern for me, because you see the effects happening on a small scale. Imagine how detrimental it's going to be compounded over months, years, or decades.
I have a question from my personal life, and it's really out of left field. So this might be something you can't answer. But I know someone who has had quite a few surgeries. And every time she has a surgery, she comes out with she ends up being allergic to something new every time. So the last time it was nuts, I think. So she's just, with every surgery, she's able to eat less and less. Do you know what's going on there? Have you heard of this?
Allergies are one of the most confusing things in modern medicine. So I don't know why that happens. I do know that allergies can change with altered states of consciousness, and that there is a very heavy top-down control over allergic responses to some types of allergies. I'm not saying the person who has a peanut allergy should go think their way out of eating peanuts and then die 30 minutes later. That's absolutely not what I am condoning. But allergies are not as fixed or as genetic as we believe, as would be easy to believe that they are. And altitudes in consciousness can affect how our body responds to what we perceive to be an allergen, which is the inciting agent.
Yeah, it's very strange because, I mean, I'd never heard of it before. Have you seen this in your own practice?
I have had patients who come in telling me they're allergic to something, and we give it to them under anesthesia and they're just fine, which
Really?
suggests either inaccurate label. I mean, you could start from the beginning and see where did this happen, right? But perhaps the most interesting story was from one of my teachers. He told me that he used to be very allergic to cats. And decades ago, he was on an acid trip. And I'm not condoning any illegal hallucinogens or any psychedelics. Please don't take that the wrong way. But this story is interesting because as a physician himself, he said that in this particular trip, a cat he was in a park or something, and a cat jumped on him. And from that day forward, he didn't freak out at the cat. He didn't think, oh my gosh, I'm allergic to cats. I can't be near a cat. From that day forward, he never had a cat allergy again. I can say in my personal experience, I used to not like my sister's cat growing up. And I would get hives whenever the cat would come near me. And I put other cats and they did the same thing. And I'm like, I just don't want to have any cats. And then fast forward 15, 20 years later, I wanted to get a cat for myself to have as a company for my dog. But I was always allergic to cats, right? I told myself I was allergic. So I went to find a hypoallergenic cat. And I drove 2 hours with my wife and some friends to go find these hypoallergenic, very premium, we call them designer brand kittens, $2,000 a kitten. And I'm like, if I'm going to get a $2,000 kitten, I'm going to stress test myself and literally grab these kittens and wipe them all over me. And I don't want to get any hives if I'm going to pay $2,000 for a kitten. I hope I'm not being cheap here. It's just like, I don't want to be stuck with an allergy in the house, right? I think subconsciously I didn't want to pay the money for the kitten. So I got hives instantly. And the cat owner was like, oh my gosh, I've never seen anyone have these hives to these kittens. They're the most hypoallergenic. They're called Siberian cat kittens or Siberian cats, I think is the name of the breed. Anyways, 2 weeks later, I got a backdoor kitten from a friend for free. And that cat has never given me allergies. I would pick her up, but she's not around me right now to give you proof. Once again, there are so many variables in this story, right? Maybe the cat is producing different levels of the dander that might be giving me the allergy. But I hope you can see from the story that treating allergies as binary, genetic, deterministic outcomes is probably not reflective of the reality behind these. I never had an acid trip with a cat. I personally don't use any of these drugs, but I do believe in the power of meditation and the mind-body connection, which I very much was keenly aware of when I got the new cat. And by the way, same for the dog as well. I've never had any allergies to my dog, even though in the past growing up, I always felt like I was allergic to them.
I would love to know if there's some sort of a psychedelic therapy that could be taken to remove allergies. But on this topic of the mind-body connection, what do you do when there's a patient who is allergic to substances and they're not able to be put under using the usual suite? So, for example, you have a patient who, for whatever reason, you can't use the usual drugs. Does hypnotism work? Is this something that's real? Is this something that can be used in theater and is used effectively?
What a fascinating question. So we have to talk about the history of anesthesia and medicine, because before the 1840s, we really didn't have general anesthesia. Yet surgery has been happening for thousands of years. So how did we do surgery before anesthesia? Well, one very dirty way was to use a combination of the three pseudo-natural anesthetics out there. They're not anesthetics per se, but cannabis, opium, and alcohol have been around for a very long time. These were used in lethal mixtures, if you will, that killed many people. but did allow some very primitive surgeries to happen. That's one type of prehistoric surgery, if you will. The other one was with acupuncture and plus or minus hypnosis. There are certainly cases that this can be done, it was done successfully. And in the beginning of the 1800s, there was this talk of what's called mesmerism. The term mesmer comes from Dr. Mesmer, who I think may have actually been from your country. He wrote about this animal magnetism, which none of us really believe is accurate, but in the beginning of the 1800s was building up some momentum. But with the advent of general anesthesia, and in Boston, the first public demonstration, the mid 1800s, the work that Mesmer had tried to translate into hypnotism for the purposes of having more comfortable, less traumatic surgery, that whole effort was just thrown out the door, because once we had ether, which is so much more predictable, why do we need to even deal with the uncertainties and the variables and unknowns of hypnotism? Well, fast forward 100 years later, and now we discover that, oh, actually, ether-based anesthetics might cause harm in the elderly, postoperative cognitive deficits. And we're doing surgery on children younger than ever before. And while it certainly appears to be safe to put these young children under anesthesia, if we have ways that we can avoid giving them these medications, would probably be preferable, certainly to the parents. I would imagine most parents. And there's been a revival. And, well, what can we do with hypnosis? So that's kind of the historical trend for why we're revisiting this, especially with opioid epidemic and all sorts of mental health conditions that have led to the awareness that a lot of these medications can worsen addictions, can affect other long-term outcomes that are not desirable, right? In my experience, I don't do hypnosis for a replacement to general anesthesia. However, especially in older individuals, if we can do the case with numbing nerves and we can reduce the need for general anesthesia or eliminate the need for general anesthesia, I find it is more helpful to provide therapeutic or hypnotic suggestions to these patients, actually speak to the patient, connect with them when they're in that threshold state that I said earlier, where you're not giving them so much of a sledgehammer, but more of like an elegant precision type of anesthetic. And your anesthesia dose, even if it's lower, will be more meaningful. It is synergistic with the top-down approach that you employ with the hypnosis. That is where I view to be a much safer, more elegant, and ultimately more comfortable anesthetic, because the other variable that you're affecting with the hypnosis is more than just the 0 and 1, because you'll get through the surgery just fine. But will that patient wake up with more pain after, with more nausea after, maybe with PTSD after? Those are the things that don't work their way into the 0 or 1 measured outcome. But if the therapeutic suggestions in the hypnosis can help affect those variables, which we know it can, that is a win-win situation where we can really integrate modern anesthetics with this age-old wisdom.
But so what does it mean in practice? So you have the option of sedating someone, but you don't want to put them completely under. And so does it look like you give someone a local anesthetic, something like this, and then it's through? What happens at that point? What do you mean by hypnosis? Is it just a general suggestion? Do you have techniques? What do you mean precisely?
So actually, in your country, in 2020 and in 2022, two large randomized clinical trials were used of actually putting headphones on patients under general anesthesia. So this is beyond what I'm talking about. This is looking at patients that are unconscious, whose brains are literally turned off. They're not responding, certainly, to any meaningful verbal suggestion, as far as you can tell, because they're not even responding to being cut open by the surgeon. That's how much you turned off the nerves in their central nervous system. Yet, when they woke up, the patients had received the recordings of therapeutic suggestions about the safety of the surgery, how it's proceeding safely and as expected. And they actually, I think, I emailed the author, they sent me the script, and the script may even be available in the appendices. This is not like anything unexpected.
Yeah.
It's just compassionate and respectful and providing dignity to the patient who's otherwise has no dignity because they're naked on an operating room table. Those patients woke up with less pain, fewer opioid requirements. In their follow-up study in 2022, they looked at the patients who were at highest risk of having nausea after surgery, which is a known side effect of the anesthesia and surgery experience. And those patients who had the recordings that emphasized the body's ability to naturally overcome nausea, they were less likely to have nausea as well. Now, we have medications that can help nausea, but I'll tell you, if it doesn't help everyone, and some patients will rate their nausea after surgery as worse than their pain after surgery, even with the medications that we try to throw at them. Tell me how fascinating and really how devoid of risk such an intervention is. In a day and age where everything is expensive and riddled with side effects, therapeutic suggestions, to my knowledge, in these conservative ways of delivering them, don't have those risks or costs or side effects.
So the image I had was, someone has a pocket watch that they're putting someone down with, but no. So what you're saying is there is a place for, in combination with modern anesthetics, suggestive practices which put someone into the correct mindset to have a good outcome for the surgery.
Just like before you go to sleep at night. Imagine if you go to sleep angry at your partner or anxious about, is my alarm clock going to wake me up on time for my big, meeting tomorrow? Or is it kind of cold here? Or am I uncomfortable? That influences how you sleep. You might wake up less restored. You might keep waking up in the middle of the night. That mindset priming is a key part to any altered state of consciousness, whether it's sleep or whether it's anesthesia. But the stakes are higher with surgery and anesthesia. So what you said is at 100% correct and accurate. It's not this yo-yo. We're talking about using modern medicine and integrating it with self-efficacy.
So you've mentioned a few times drugs in the discussion. You're in California, so people hear about the drug epidemic that's happening in your state. And one thing I'd like to find out about is, how does that translate in the operating room for you? What are you seeing on the table?
It's very unfortunate. I'll just be blunt about this, because just like how you mentioned earlier, how when someone is lonely, when they're depressed, when they have unmitigated anxiety, when they are suffering from PTSD, this has a tangible effect on the patient, whether how they fall asleep, how they respond to the anesthesia doses that you give them, or how they wake up. Well, having an addiction is even more effective, is even more tangible, I should say, more tangibly observed in the operating room. First and foremost, because there is a tolerance to any substance that the body sees. So in the case of the fentanyl and the opioid epidemic here in San Francisco, where I live and practice, there is a tremendous amount of illicit opioid use, often in the form of fentanyl because it's cheap, and they cut it with many other drugs because it's cheap. Well, they're going to need, surprise, surprise, so much more opioid to keep them under anesthesia. Well, that has risks with it, because you can't just give more medication and not expect to have more side effects from it. Ask any addict who needs more and more of a medication to get the same high, but they'll still pass out at a high enough dose, and then you know how the story goes. The other issue is that addiction rarely exists in a silo. Addiction is not as much of a diagnosis, I believe, or how I work with patients, as much as a symptom of something else. So the fentanyl is providing, as you can imagine, some level of comfort because something else is missing. Well, are they depressed? They're trying to fill that void with the fentanyl, or is it any number of other conditions that also have a compounding effect in the operating room? Oftentimes, this affects pain management after surgery, in addition to the actual experience in and of itself in the operating room. The other big medication is marijuana. And I am not going to say I'm anti-marijuana. No, I personally don't use it, but there are medicinal benefits when used at certain doses in particular ways in some patients. It is very difficult to measure because it has a highly variable effect on individuals, very similar to coffee. Yet, patients or, people I'm sure that can have, one cup of coffee in the morning and they can't sleep that night. Right? And there's some people that can drink a whole, bought a whole, I don't drink coffee either. I'm
a whole can.
A what?
A whole can.
Yeah, a whole can at night, and that'll sleep just fine because caffeine just has so much variability on its effect, presumably based off of genetic or maybe some other variables in individuals. Well, so does weed, especially when you have so many very finely cultivated species and breeds of marijuana that have exceedingly high THC concentrations. This has very, very direct consequences in the operating room, on par with fentanyl. In terms of, one study showed 200% the propofol dose required. So literally 2 times as much propofol required for patients that use weed every day. And daily use of weed is increasingly common amongst the population that I treat. That's in addition to other consequences it can have in the operating room in terms of, once again, pain management, side effects, more nausea, etc., after surgery. But it's most alarming to me that if we're observing in a 25-year-old really immense changes in how their brain is functioning, because it literally needs 2 times the amount of anesthesia, what's going to happen in 10 years, in 20 years, in 30 years? When we talked about cognitive reserve at the beginning, I have serious concerns for how this brain is going to adapt in response to chronic marijuana use. And by the way, natural weed has about 2% THC. So when I see strains that are actually called anesthesia strains, it's very funny to me, that are in the 30% range, or butane hash oil, 90% range THC, this is no longer a natural plant that has the natural push and pull, agonist, antagonist mixture of chemicals, right? Think of tea versus a Red Bull caffeine shot, right? They're very different because tea has caffeine and theanine to counteract, versus the Red Bull is just, I don't know if they have Red Bull in Germany, but Red Bull is like,
yeah. It's everywhere.
Well, there you go. When you have a THC, and the BHO, butane hash oil, that's like the Red Bull, and you're going to have effects. But unfortunately, nobody seems to know about these effects. They look at me like I'm crazy, or like worse, that I'm judging them before surgery. And it's like, no, I need to know so that we do your surgery safely. Same goes for every other drug.
Are you sometimes then going into surgeries not sure what to expect?
Let's just say that I want to say every medical student, at least in the United States, at some point is probably told, certainly I was, that 1, trust but verify. 2, whatever the patient says, double it. And I know this can come off as being disrespectful to patients, and that's not my intent. These are heuristics that physicians learn to ultimately have a safe practice. Hopefully no one is judging anyone, because that's not productive. We want to deliver safe medicine to people. So when someone says they drink alcohol 3 times a week, they always tell us to double it. If it's 2 joints a day, double it. Now, I'm not saying this is everyone. I'm not saying all patients are dishonest, but the reality is that these are sensitive topics, just like sexual practices, what you eat, how much you exercise. Patients are not fully honest because of fear, and there's sometimes legitimate fears. If you have a jerk doctor asking you these questions, there's going to be defensive mechanisms. I'm not blaming the patient per se, but I'm pointing out that there has to be honest disclosure if you want to have the best medical care delivered.
Then let me ask, what do you think of drug legalization? So from your perspective, how does the argument look?
Mm-hmm. Could you tell me a little bit more? Because that's a huge question that has no easy answer, certainly.
Right. So often in the discussion, you'll have very liberal people who are very keen to legalize everything. Right? Legalize everything. People have the right to do what they want with their own bodies. And then on the other side, you might have a position which runs along the lines of, there are costs to society of legalizing certain drugs. For instance, you might end up, I know where in LA, you have these open areas with very visible drug abuse and people that are really suffering. And one side of the argument might say that drug legalization would just lead to more of that. There's a social cost. And so I kind of wanted the question to be broad, really. As someone who deals with patients every day, where they're most vulnerable, and where you really want to deliver the best service, you want to make sure people are safe. You might have a perspective that people don't think about, right? People don't think about what happens in the operating room necessarily when they're discussing this argument, and so that's sort of the direction I want to. That's the direction I want to come from. What else can you add to the argument? What else can you add to the discussion because of the unique job that you have?
I really appreciate the perspective that you have, because everyone is entitled to have an opinion on this, but the opinion should be one that is based on both data and experience. Because while the data might show X, Y, and Z, when one has to actually look a loved one of a patient in the eye and explain a complication, a fatality, something unexpected that happened, and have to see how this could have been prevented with the appropriate intervention to prevent drug use had that been responsible, which, by the way, drug use is responsible for an enormously high, I'm going to say this is probably around the world, an enormously high percentage of fatalities in individuals under the age of 35. In medicine, we say drugs, sex, and rock and roll. But that is a very difficult conversation, a very heartbreaking conversation to have, in addition to having to see the patient be under immense pain and hardship, and if they make it out alive, right? So I invite anyone who wants to be a decision maker, and I have invited lawmakers. They've never taken me up on this. I invite them to come with me in the operating room, or to come in an emergency room with myself or another physician for a week. Because the emergency room is really where this gets hit the hardest. Because to come to a surgery, you need to be a surgical candidate. If you are so off the deep end because drugs have ruined your life, you may not even be a surgical candidate. So I may not even see you unless it's a trauma surgery, et cetera, et cetera. But the emergency room environment sees so many individuals who have lost their lives. And in the US, it's different than in other parts of the world, because we make, in San Francisco where I live and in LA where you described, these drugs are legal. I would say functionally legal. And yet there is no capacity to help treat those that have problems, which is just simply, and that does not help with the emergency room, nor does it help the operating room. The view that I have that is highly controversial in the United States is one that is becoming increasingly talked about, because there are no other solutions, especially here in San Francisco, at least no other solutions that have worked. And that has been that at some point an individual loses capacity to care for themselves. I know it's not an easy topic to discuss, but I would not want somebody with a lethal kidney infection to be walking around the street, to die on the street, nor would I want somebody who does not have the ability to take care of themselves because of a severe psychological disease to be walking around to be a threat to themselves and a threat to others. I believe that it is not compassionate to let somebody come into the emergency room every week getting a CT scan of the head because they got drunk, passed out, hit their head, and accumulates 10, 20, 30, 50, 70 CT scans a year because of the revolving door. That does not appear compassionate to me, especially when the individual, because of a lack of clear thinking, has refused treatment that has been provided by the public. Not everyone agrees with this view. I want to really be as respectful and give as much dignity to anyone who's suffering as possible. But it is not appropriate to make harmful substances legal without providing in parallel the education for an informed decision. And I took this up with the state of California that wanted to legalize psychedelics, natural psychedelics, with the exception of mescaline. And what was disheartening to me was that, one, the side effects of psychedelics were not known by the policymakers I spoke with. And as a doctor and I use ketamine for mental health all the time in patients, I have a ketamine clinic just for this. I believe in the power of such substances when used responsibly and ethically, knowing the side effects. It is concerning to me when lawmakers want to make these things fully decriminalized, which is just one step to eventually making them even more legal. Already in San Francisco, these things are, like I said, functionally legal, but there is no education. It's the patient whose eyes blow up when I tell them, and it's the first time they've heard anyone tell them the risks of something as relatively benign as weed, right? Like, how does that patient feel? Think of how terrified they are. If I told you the number of times a patient has been afraid to even tell me because of so much self-doubt, how much weed they smoke until the last second before the mask goes on under anesthesia, that's not the mindset that's going to lead itself to an optimal anesthetic or an optimal surgical recovery. And that fear is there because of lack of information. I should not be the first person telling this patient. They've had weeks knowing they're going to have surgery. It's not like it was a trauma where they came in 15 minutes ago. Yet, that's just not right. Society is failing. So wherever you stand on legalization, you can't ignore the education that has to be in parallel. And that's all I want to advocate. And I hope everyone agrees with that.
So if I understand your position correctly, you need adequate services available if you are going to be legalizing these substances in short form.
Thank you for that succinct explanation. And even if they're not legal, you still need to have support.
I realize that you have to start your live conversation in a little while. So I'm going to move towards the end of the discussion, being respectful of your time here. And I just have a few more questions that I'm curious about. So just to give you an idea of where we're going, I want to ask you a little bit about what it's actually like in the operating room for you. And then I want to talk about a bit of the future. So let me ask you a little bit about life in the operating room. Do you get to see every type of surgery there is in a hospital? I ask because I imagine surgeons have their specialties, but you're an anesthesiologist. So does that mean that you really are in every single one of the rooms, seeing every single type of operation that's going on?
Very good question. There are some specializations, but by and large, an anesthesiologist will see the vast majority. The few areas of extreme specialization include cardiovascular or open heart surgeries and some neurosurgeries. By and large, you're doing pretty much anything that's out there. There are some other surgeries in the lungs that might be hyper specialized. That being said, most hospitals do not perform all these surgeries. So if you're an anesthesiologist at one of the hospitals, you're going to realistically see whatever is reflected in that hospital's capabilities.
But let me lead on with the question anyway. Are there any surgeons you're particularly impressed with?
There are some I'm particularly not impressed with. It goes both ways. There are fantastic patients, and there are patients that put roadblocks in front of their own healing. There are surgeons that make their own lives and the lives of those around them more complicated. And there are surgeons that inspire everyone in the operating theater to bring out their best. So there's a variability, just like any profession.
So there's some people that you really love working with, in other words.
Yeah.
Can I ask, is there a hierarchy in the operating room when it comes to the chief surgeon and the anesthesiologist? Is that who has the final call when it comes to tricky decisions?
That's a very good question. It's a function of the time. Before the surgery starts, the anesthesiologist, before the surgery starts, the surgeon needs to say that this surgery is appropriate for the patient. No one's going to contest them on that. But then the anesthesiologist has to say that we are going to proceed with surgery or not, because the anesthesia may or may not be safe for the patient at that time. As the patient goes under anesthesia, the anesthesiologist is in control. Throughout the procedure, the surgeon is going to be calling shots because of where they're operating, but that often is not independent of the anesthesia. So at the end of the day, the anesthesiologist and surgeon need to work together. And at different points in time, one or the other is going to, if you will, something hits the fan, they need to come to a decision very quickly, because you can't just wake up a patient instantly if their belly is split open, nor can you continue a surgery if the patient is going to not make it because they can't tolerate the anesthesia. Unfortunately, you can imagine two doctors can have sometimes big egos, and that can lead to lots of clashes. And that's often what explains the variability in who you want to work with.
So then, moving outside what's currently happening in our hospitals, are there any exciting developments on the horizon, or are there any new techniques or drugs that are coming in that you're particularly interested in or excited by, or that make your job easier?
It's a very good question. Unfortunately, there are not too many medications that, at least I'm aware of, in the pipeline, with the exception of a medication called remidazolam, which is very interesting, but I just don't know if it's going to come, and when it does come, how expensive it's going to be. I think the most fascinating for me personally, medical technology has been the portable ultrasound, where I can literally just bring an ultrasound in my pocket and look at the heart, look at the lungs. I can look at nerves and block them with just one probe that I plug into my phone. That has been transformative, because now I can do so much more at what we call point of care, right at the patient's bedside. I don't have to send them off to get an x-ray. I don't have to send them off for this. Now, these are crude measurements, but with every level of technological advance in these technologies, that level of crudeness becomes more and more refined and is absolutely transformative. And I find that to be fascinating. So it lets us do things we could not do as quickly or as safely before.
So let me wrap up with two questions. What's special about life? Right now, because let me preface this by saying, look, you deal with patients when they're at their most vulnerable. You're sort of at the border of consciousness with patients, as you said, who are naked on the table. So what's special about life?
If we knew how much we stand in our own way, if we had the courage to step out of our own way and let us do what we are literally programmed to do, which is to be compassionate to ourselves and to be compassionate to others, we would be a much healthier and so much happier and more fulfilled, purpose-driven society at the population level and at the individual level.
So let me ask you the final question. I never asked you initially why you got into the job, right? So what do you love about the job?
I was an engineer before I was a doctor, and I always wanted to fix problems like any good engineer. And there were two problems out there to solve, I figured. One of them was the healthcare problem in the US, and the other was energy, because obviously the whole world needs more reliable, cleaner, cheaper energy. I decided to go down the medical route because being the son of immigrants, that was clearly the right answer. And because I was an engineer, I loved the technology and the devices that were intrinsic to the operating room, and especially anesthesia, where you are dealing with measurements at a resolution, at a time scale that you don't have anywhere else in medicine. Nowhere else in medicine do you give a medication and within seconds see its response. It is not only satisfying, but it makes you very good at what you do, because your feedback time is so darn short. You give the medication, you do the technique, you have instant feedback, And you can see a patient transform for good or for bad. And when you learn how to do it for good, whether it's through hypnosis, whether it's through holding their hand, or whether it's through giving them the medications that they'll never know that you gave them when they were asleep, you are really making an impact on a time scale that nowhere else in medicine you get to do. It's not like you're waiting 10 years to prevent a heart attack. So call me impatient, but it's very gratifying and just so fun and intellectual because no patient is the same. Imagine showing up to work every day and having a different project to do multiple times a day. That's exactly because no two human beings are the same, even if the surgery is the same. You're having people with different backgrounds, different fears, different phobias, different medical histories, and you need to make a square peg fit in a round hole multiple times a day. And it's actually very fun.
Anthony Kaveh, thank you for coming on the podcast.
Thank you for the insightful questions.